Yeah.
So, a very good evening, everyone. I am Dr. M. Shah Jaiswal, currently studying in Busan National University, South Korea, and I am the host for today's session. Today, we have Dr. Ashwin Mullat, sir, with us. He has done MDS in oral maxillofacial surgery from KMCT Medical College and Hospital. Along with that, fellowship in oral surgical oncology and head and neck reconstructive surgery from Malabar Cancer Center. Moreover, he has also done fellowship in aesthetic medicine from Greifswald University. So the today topic of this session is comprehensive clinical aspects in diagnosis and management of oral cavity and head and neck cancers. So this topic seems to be very interesting as we need to make surgeons and dentists aware for improving the cancer survival rate by application of several recent advancements in surgical techniques. And we can also learn about what other modifications that need to be taken to improve the current statistics in India. So before starting this session, let me tell few points to all the attendees. If you have joined live from YouTube and Facebook, and have any queries or questions, you may ask by commenting and you will get your answers at the end of the session. And if joined via Zoom, you can write your questions in the Q&A box in the control panel and it will be answered accordingly. So all over to you, Dr. Ashwin. You may start now.
Okay. Thank you, Dr. Shriya, for the warm introduction and the nice overview of the topic. Then, without wasting much time, I'll be directly moving ahead with my topic. Dr. Shriya, my presentation is visible or like?
Yeah, it is visible.
Okay. So once again, myself, Dr. Ashwin. Today, I'll be dealing with the topic comprehensive clinical aspects in diagnosis and management of head and neck cancers. So as Dr. Shriya told, the topic seems little interesting, and at the same time, it has a great scope for a lot of discussions around that. So it is a very vast topic. So today, basically, what I am doing is I will be concising all the aspects of this head and neck cancer, and with more emphasis on oral cavity cancer, because most of our colleagues are from the dental background. So, yeah, I hope my slides are visible. Yeah, fine. Okay, so coming to the introduction, so head and neck cancers, mostly the head and neck cancers collectively, they arises from the squamous cells that line the mucosal surfaces of head and neck. That means inside mouth, throat, larynx, etc. So mostly they are collectively referred to as squamous cell carcinoma. More than 90% of these head and neck malignancies are from squamous cells, and the histological pattern varies in that aspect. That's why they are called squamous cell carcinoma. Then few others like the tumors or cancers arising from salivary glands, sinuses, muscles, nerves, etc. also can happen in head and neck. So they are way less common. So now we have cancers of head and neck. So we can typically, already we discussed about the squamous entity, squamous cell carcinoma, non-squamous cell carcinoma. So we can, based on that itself, we can have a classification. So we can group it under two. Squamous cell carcinoma. What are the squamous entities? What are the non-squamous entities? So squamous, basically cancers of the oral cavity, oropharynx, larynx, hypopharynx, nasal cavity, nasopharynx, then paranasal sinus. So these all groups, mainly the main pathological way in this squamous cell. So coming to the non-squamous cell varieties, mostly it is carcinoma thyroid. Everybody will be aware about that. Then carcinoma of salivary glands, including parotid and other major and minor. Then sarcomas. So here in this picture, you can see the subside distribution of head and neck. You can start from the oral cavity. Here we can see the oral cavity and its subsides from anterior tongue, lip, floor of mouth, alveolus, gums, etc. Then posterior tongue. So the posterior tongue is not considered to be a part of oral cavity. It has to be on the oropharynx. Then starting from the posterior tongue, palatine tonsils, then posterior pharyngeal wall, soft palate. All these things together constitute the oropharynx. Then below that, again, we have one more division, hypopharynx, then larynx. So these are the superiorly we have the nasopharynx. So these are the various anatomical subsides in head and neck. Coming to the brief introduction, this kind of head and neck squamous cell carcinoma, it is the sixth most common cancer worldwide, and tobacco-associated SCCs arise primarily in oral cavity, hypopharynx, and larynx. In case of oropharynx, there is little difference. It is mostly based upon not mostly based upon, but there are high level of incidence about human papilloma virus. Then about this HPV entity, we will be discussing in our coming slides. Then this head and neck cancers follows an ordered series. So it starts, it will be beginning with epithelial cells, with dysplasia, mild hyperplasia, then followed by dysplasia, which can be mild, moderate, and severe, then carcinoma in situ, and ultimately our invasive carcinoma, that means squamous carcinoma. So it is like a series of events happening in and around. So this is the region-wise distribution of various subsites in head and neck. So this is not universally applicable. The first thing is that this kind of region-wise distribution depends upon the population. So this will not be applicable for the Asians. It will be different for the Asian kind of population. It will be different for the Western population. So it has little variation. So basically speaking, oral cavity accounts the most. So it accounts for more than around 30 to 40%, then followed by larynx, or in some countries or some populations, hypopharynx have slightly more predilection more than larynx. So this is the pattern. So all we have to know is this oral cavity have a more significant high predilection. Then coming to epidemiology. So before going into the core topic, we should know what's happening in and around us. What's the statistics? What's the database, etc., in and happening around us. So there is something called Global Cancer Observatory database. So this is nothing but it is a database. It covers all the cancer statistics. It estimates for the incidence and mortalities. So this their data, they cover up to 185 countries for 36 different types of cancers. So here you can see the map and you can see the different cancer distribution. And out of that, you can see the green indicated in more Western countries, Americas. So that is carcinoma prostate. So carcinoma prostate in the world, for world distribution, in case of the world distribution, carcinoma prostate accounts the more. And you can see the brown indicated lip and oral cavity. That means coming to the head and neck cancers. So it accounts mostly for the South Asian countries, mostly India, Sri Lanka, and all of these other South Asian countries. So this is it accounts it carries the sixth position. So this is the site-wise distribution of different cancers all over the world. So this Globocan, what else they tells us? So they initially, what we have to know is these kind of cancer databases or data registries, they'll be telling us the site-wise distribution, then they'll be telling about the incidence, mortality rates, and all together they will be giving a brief description of each and every cancer. So here you can see something like very interesting, very high HDI, Human Development Index. It is similar to, you all will be aware about this GDP. So this is similar to that, but here what extra that we are having is here the level of education of the people, the quality of living, all these kind of things, they are included. So it is superior while comparing to GDP. So the Human Development Index, mostly this cancer data, Globocan and other cancer data registries, they use this HDI asset tool. So according to that, you can see lip oral cavity. Coming to head and neck cancers, again, lip oral cavity. This is the worldwide distribution, not particularly to India. So low to medium HDI. So they further classified this HDI as low, medium, high, and very high. So India, our country, India belongs 131 rank out of the 189 countries. So that means they are under medium HDI. So in such kinds of low and medium HDA, this lip and oral cavity accounts more, like 10.2%. Out of that, this is the incidence of the cancer. Then you can see something on the red graph. That means this is the primary. Blue indicates incidence, the red indicates the mortality rate. So the mortality rate is also comparatively high along with the incidence rates. So in the right-hand side, what we can see is the high and very high HDI countries. So there, in those countries, incidence is also less compared in the similar way, mortality. So these graph, what they tells us is like the socioeconomic status of the people or socioeconomic status of the population also do have an important role in the development of head and neck cancers. So coming to now, we already saw about the global distribution. Now we can see Global and India. Global in what they have to tell us. So this is not the total incidence of the cancer. You have to remember this is the number of new cases. Every year there will be new cases. So the last Global Can update was 2020. So according to that time, the number of new cases together, like both sexes, males and females, in all age groups. So this majority 56.5% other cancers. That means like hematological malignancy, lymphoproliferative disorders, all other kind of entities, lymphomas, everything will come under that. So remaining classified group, breast accounts more, followed by lip and oral cavity, cervix, lung, and colorectal. So this is the distribution of cancers in India. So similar way, when comparing with male and female, you can see lip oral cavity accounts for the most in males. So this can also give us relevant information regarding the etiology, the habits, all kind of things which we will be explaining in our coming slides. Then etiology or risk factors. What are the etiological factors that we mostly see? I will be just briefly going through all those things because we have to know, in order to treat the patient, we should know the origin of the disease or the risk factors, how to avoid that. So basically coming to etiology, alcohol and tobacco use. So everybody will be familiar, everybody will be knowing that this can cause cancer, then how it can cause cancer. So the combination of alcohol and tobacco, that is like a deadly combination. So alcohol itself cannot cause cancer. So alcohol is having a synergistic action in combination with tobacco. Tobacco is having more than 70 non-carcinogens, including aromatic hydrocarbons, nitrosamines, etc., in both smoke and smokeless form. So along with this tobacco, this alcohol acts as a solvent. It increases the mucosal permeability of this contents of the tobacco in the oral cavity or upper aerodigestive tract. And alcohol can also inhibit the DNA. It can provide various enzymes. It can inhibit the DNA repair mechanism. In a lot of other indirect ways, alcohol and tobacco, this combination is the prime etiological factor in case of oral cancer. So then dental factors, as you all know, these sharp tooths, these ill-fitting dentures, all these can contribute. If you are getting a patient, you can take a history, these kind of things. If the patient is like a never alcoholic, never tobacco user, so in such kind of patients, you can see either these kind of things like sharp tooths, ill-fitting dentures, etc. Then viruses. The role of viruses, as I told in the introductions, like human papilloma virus. So the type 16, HPV 16 have significant role in oropharyngeal carcinoma. That means carcinoma of base of tongue, tonsils, etc. So how this oral HPV has a role? So HPV, now there is some classification staging by American Joint Cancer Committee. So those things we'll be explaining in the later slide, but I'll be giving a brief outlook of that. So this HPV status is very much important in our present scenario. So HPV positive cancers in Indian population, around 30% of the oropharyngeal cancers have HPV positive status. Thus, it became a surrogate marker. But at the same day, one good thing is that HPV positive cancers has good prognosis. It is highly radiosensitive. Mostly it happened for the young individuals. So it also got a good prognosis in other way. Then HPV negative cancer, which acts similar to other oral squamous cell carcinomas. Then Epstein-Barr virus has high role in nasopharyngeal carcinoma. Then occupational exposure, occupational exposures, radiation exposure. The patient who underwent radiation for other cancers in head and neck can cause cancer in thyroid and or other salivary glands. Then underlying genetics. So in genetic disorder, Fanconi's anemia, it is like familial disease because in Fanconi's anemia, there is an incidence of around 3% of developing head and neck cancer. So then other entities, immunosuppression. Immunosuppression, it can be either after a organ transplant surgery, the patient will be having a chronic immunosuppressive status due to the drugs, or it can otherwise cause due to the other immunosuppressive disease such as HIV. So briefly, these are the etiology. So here you can see a pictorial representation of what we discussed here. You can see multiple agents which are non-carcinogens. So these carcinogen exposure can cause carcinogen metabolic activation. So either it can detoxify or excrete itself, then the patient will be again healthy, or it can cause DNA damage. If the body or the host response, it can repair the DNA, again the patient will be healthy. Or otherwise, what happens is if the further mutation, deletion, and amplification, then what happens is the development of head and neck cancer. Biology of tumor growth. There are multiple stages, malignant changes in one cell, which can transform to other one, then local invasion, then distant metastasis. Then now we are moving on to the clinical presentations of typical head and neck cancers. The mostly found one is oral cavity. So it usually classically present as a non-healing ulcer. The patient will be always complaining about a non-healing ulcer of some more than 1 month duration, 2 month duration, something like that. So in educated or higher socioeconomic background, these oral cavity cancers has little early stage diagnosis owing to the patient's self-identification of the lesion due to the symptoms, because it interferes with whatever things we are doing, like basic things, eating, speaking, whatever it is. So in that cases, oral cavity early diagnosis is always is the, we can have an early diagnosis in case of oral cavity. Then another thing is clinical suspicion of any lesions of oral cavity can be, we should have a proper case history. We should take the proper case history of all the patient's adverse habit, deleterious habit, and we have to correlate that along with the lesion. Then next, coming to the anatomical subsides of oral cavity. So oral cavity is subdivided into further subsides like lip, buccal mucosa, alveolus, retromolar trigone, floor of mouth, hard palate, and the two-thirds of tongue. So here we can see some clinical variations in oral cancer. So the very first picture that you can see over here, you can see a proliferative ulcer. There is enough. You can see an ulcer. There is a proliferative conduct. So here, this exophytic ulcer, this can be classified or this can be termed as ulceroproliferative growths. Then the very second picture, it is also a proliferative growth, but it has like a pedungulated mass. So these are kind of verrucous carcinoma. The third one is very deadly. It is an infiltrative lesion. So the third one, it can be either ulcerative, ulceroindurative, or ulceroinfiltrative. Both stand same. So basically, what we have to know is, while describing a cancer or while describing a lesion in oral cavity, you can start with like an ulcerative lesion or an ulceroproliferative lesion or an ulceroindurative lesion where there is definite induration present. So this ulceroindurative lesion or ulceroinfiltrative lesion is more dangerous compared to this verrucous growth and ulceroproliferative kind of growths. Coming to oropharynx and hypopharynx. Here in this picture, you can see an endoscopic view of hypopharynx. So what you are seeing here is like, these are the bilateral pyriform sinuses or pyriform fossa. These are the subsides of hypopharynx. And this is the post-cricoid region. Here you can see a proliferative tumor over the pyriform sinus. Here you have, in bilateral side, you have the esophageal inlet. So mostly what happens for these kind of cancers, oropharynx or hypopharynx, late diagnosis. Why? Because it usually they are at a hidden anatomical location. So basically when present such patients will develop in advanced stages as progressive dysphagia, odynophagia, that means difficulty in swallowing, that means painful swallowing, difficulty in swallowing, dysphagia, then painful swallowing, then otalgia, that means ear pain. Mostly it will be referred pain due to the neural conduction mechanism, which all these subsides will have similar nerve conduction pathway. So the lesion from the base of tongue can cause ear pain through the glossopharyngeal nerve, which also supplies the middle ear cavity, and it can also, another lesion from the lower alveolus, it can cause middle ear through the auriculotemporal nerve pathway. So these are things in common. So these kind of presentations, we have to look for a hidden upper aortodigestive tract lesion. We have to search for that. Like in previous slide also, I mentioned we have to see the patient history first, like patient habits, risk factors, etc. Then coming to laryngeal tumors. Laryngeal tumors, voice change, hoarseness. So the another types of cancer that where we can have early diagnosis. So the voice change or hoarseness is an obvious kind of thing. So suppose the patients will be coming to you with a complaint of change in voice since past 2 months, past 1 month, or past 1 year. So beyond that, it will be like advanced stage. So in that case, the patient will be presenting with dyspnea, difficulty in breathing, or sometimes patient may end up with stridor. Here you can see an endoscopic view of carcinoma larynx, to be more specific, carcinoma glottis. Here what you're seeing is vocal cords, right and left vocal cord. This is the normal right and left vocal cord. Here, this right side, you can see one ulcerative lesion over the right vocal cord. So this is the laryngeal inlet. So this is the main basis of airway. So what happens in laryngeal cancers, if these two vocal cords have the function like adduction and abduction, this can further help in phonation, airway. So during phonation, the vocal cords will adduct. So in that case, if a tumor, if it is in advanced tumor, it can fix this vocal cord. That means fixation of hemilarynx. In that case, only the opposite cord will be compensating. So the patient will be having hoarseness. Suppose the same tumor, if it further grows beyond and it has a proliferative component, it can impede the airway. In that case, patient will be having stridor, and immediately as an emergency procedure, the patient may end up in going for tracheostomy. Then again, grade nasopharyngeal tumors. Mostly nasopharyngeal tumors, they also clinically the patient presents as a neck mass, or others in some cases in anterior nasal cavity, it can happens like epistaxis, unilateral nasal obstruction, these kind of symptoms. So mostly in our OPD or our clinical scenarios, what happens is patients will be coming to us with presenting complaint of like a huge or neck mass, neck node or neck mass. In that case, we will be evaluating the patient like a carcinoma of unknown primary. Because the patient will be having a proven diagnosis from the neck node, but will not be knowing where the exact primary is. In that case, we have to go for upper aorodigestive pan endoscopy. That means endoscopy of the nasal cavity, nasopharynx, oral cavity, esophagus, etc. So these are the nasopharynx, oropharynx, and hypopharynx. These are the sites where the tumor can hide. So now coming to the spread of squamous cell carcinoma. So as all you know, the mechanism of spread, the first one will be local infiltration. So what local infiltration means? Invasion to the local soft tissues. It can be through the perineural spaces. That means along the nerve. Then angio invasion, that through vessels, and invasion of bone. Then another common pathway is lymphatic spread. Then hematogenous spread, distant metastasis. So hematogenous spread, distant metastasis is less likely common in head and neck compared to other cancers. So then also distant mets, we have a percentage of up to 1 to 5% of early oral cavity cancers, distant metastasis to lungs. So the most common metastatic sites are lung, followed by bone, followed by liver. Next, we have to know about the neck nodal levels. So Memorial Sloan Kettering Center, New York, they introduced the neck nodal station level, nodal anatomical system. So this is accepted universally, and we are following all the cancer centers, all the universal databases are following their anatomical classification as the subgrouping of different nodal stations in neck. So here what you can see, why you want to know about the nodals. Suppose if you are getting a patient with a suspicious lesion of oral cavity, you can also check the nodal station. It is very simple. You can examine the lymph node level. The normal, all patients will be having nodes. So the reactive nodes will be soft, tender, and by palpation itself, you can somewhat elicit it. Then in case of metastatic nodes, what happens is the node will be more of rounded in nature. It will be little firm either, or it can be fixed to the underlying structure. Suppose in submandibular or submandibular triangle, if the node is metastatic, or whether we can tell it as like the node is having an extracapsular spread, it will be fixed to the underlying structure. So the most common structures like mandible, digastric, all these structures are there. So we have to know about the various nodal stations. So the neck is further divided into 7 stations, starting from level 1 to 7. Level 1A further divided into level 1 further divided into 1A and 1B. You can see the digastric muscle here. Here you can see the hyoid bone. You can see the anterior belly of digastric. You can see the posterior belly of digastric. So between the two anterior belly, the midline structure, that is level 1A or submental triangle nodes. Then between the anterior belly and posterior belly, we have the submandibular triangle. So that is the nodal station of level 1B. Similarly, level 2 to 4, from the base of skull to the clavicles, along the sternomastoid, the level 2 to 3, 4 nodal station. Then posteriorly, we have level 5, further divided into 5 and 5B, in between the posterior border of sternomastoid, anterior border of trapezius, inferiorly by clavicle. Then the second picture you can see, these are the various nodal stations where the tumors or cancers of the head and neck can harbor metastasis. So level 1A, 1B, submental and submandibular, then 2, 3, and 4 together collectively called jugular nodes, upper, middle, and lower. So these are the common nodal stations in case of primary oral cavity tumors. So we should have thorough knowledge about all these nodal stations. Now coming to diagnosis. So head and neck cancer must be, there should be a tissue diagnosis in order to establish the primary diagnosis of any head and neck tumor. So it can be either from the tumor itself, or it can be from the neck mass or whatever suspicious nodes. As I told, in case of nasopharyngeal or some kinds of hypopharyngeal lesion, there will be only neck mass. The patient will be presented only with a neck mass. So in that cases, you can have a tissue diagnosis from that nodal mass, or either in this case. Then biopsy methods depends upon the primary location of the lesion. Then suspicious cervical node, if you're finding a suspicious node, don't directly go for a biopsy. That means either it can be incision or excision. So in case of nodal biopsy, it is mostly reserved to lymphoproliferative disorders or other kind of hematological malignancies. Otherwise, in case of other squamous cell carcinomas, poorly differentiated carcinomas, if you want to do a node biopsy, it should be the primary investigation like cross-sectional imaging or endoscopy. It should be inconclusive. In that case only you can go for a nodal biopsy directly. Most of the times, as I told, if a patient presented with the upper level 1 to nodal mass with no well-known clinical primary, we'll be going for a pan endoscopy. In that case, somewhere we will be finding a lesion. We can directly go for endoscopic biopsy in that scenario. So this is a decision tree when to take a biopsy. So this is the basic kind of thing. So first, if you're finding a lesion suspicious, the main thing is take proper histories, then do basic investigation, make your own differential diagnosis. If you are not finding the lesion as that much suspicious, you can observe or do the conservative management, not more than 14 days. You have to recall the patient. You have to make sure whether there is any improvement or otherwise in that scenarios. So in the initial visits itself, some lesions will be highly suspicious. In that case, you can directly go for biopsy. If there is no improvement in your conservative management for a lesion after 2 weeks, perform a biopsy. In case of performing a biopsy, other kind of decision making, like whether you can do it or not, if you are basically thorough with the principles of biopsy and if you are confident enough to take a good biopsy, go for it. Don't think twice. Then after the HPR report, that means histopathology report, you can further refer the patient. So here the picture A and B. You can see A and B. These pictures are a little confusing. So you will be seeing whether you will be having a dilemma, like whether to take a biopsy or not for this kind of lesion. So the very first lesions, second lesion, almost similar, but you can see it resulted from a traumatic bite. So first you have to see the etiologies, whether the patient is having a traumatic tooth. You have to elicit the etiology. You can either go for restoration or you can go for extraction of that particular tooth, which evoke the change. So then you can see. Then clinical palpation. If the lesion is indurated, if you are in the inspection finding like a superficial lesion, but palpatory finding is indurated, directly go for biopsy. Don't think twice. Then third and fourth one is like obvious lesions. So biopsy types, we have different types: incisional, excisional, exfoliative cytology, fine needle aspiration, biopsy, brush biopsy, punch biopsy, true cut. So these are used in various scenarios. So mostly in case of oral cavity lesions, we'll be mostly going for incisional biopsy. Then coming to incisional biopsy, how to take a proper biopsy? This will be the question for many of the people, many of the physicians, oral physicians or the dentists or other clinicians in the same field. So how to take a proper biopsy? You can see the picture A. Always you should take your biopsy should have adequate tissue, or else the pathologist cannot comment the invasion. So for adequate tissue sample, it should have adequate depth. Suppose in some cases you'll be taking a wide biopsy, but it will be very superficial. The pathologist cannot comment invasion on such kind of things. So you have to, undesirable is broad and shallow biopsy, desirable is narrow. Narrow, or it should not be that much narrow, but it should involve the deeper sections. Then always take biopsies. Suppose if this is a lesion, always takes biopsy from the edge. Edge biopsy is always preferred. Suppose if you are getting a tumor like this, if you're taking the biopsy from the center, you will only get a necrotic material. So that doesn't mean the patient doesn't have any cancer. So always take from the edges. So the proliferative or the indurative or the tumor cells will be always, it will be tumor, the property of the tumor cells or the behavior of the tumor cells will be like infiltration. So all the infiltration cells will be on the periphery. So always take from the edge with adequate depth. Then in some scenarios, you will be getting a different, same lesion with different morphological alterations. In that case, you can evaluate the patient, you can evaluate the lesion, you can take different biopsy or multiple biopsy from the same specimen itself. Coming to excision biopsy. So for malignancy, suspicious malignancy, excision biopsy, a big no. So we should not go for an excision biopsy. So excision biopsy is best reserved for benign lesions, like proven benign lesions or long-standing lesions with close follow-up. In that case, you can go for excision biopsy. Here in this picture, you can see how to take a proper excision biopsy, but the lesion seems suspicious. So for the reference purpose, I put these pictures, but you should not go for excision biopsies in these kind of lesions also. So excision biopsy, what is the main difference from the incision? So excision biopsy will be taking the entire specimen with little, not like major radical specimen will be with adequate margins. In case of excision biopsies, we'll be taking the lesion with minimum 3 millimeter of margin. So it should be 3-dimensional. It should not be super. If you are seeing a lesion here, you'll be just seeing 3 mm all around. No, it should be in the deeper depth also. Depth should be also sufficient. So this can be done. Where to do this kind of excision biopsy? The patient with potentially malignant disorders. That means lesions such as leukoplegia, erythroleukoplakia. So leukoplekia, homogeneous type, you can follow up the patient, you can try all the conservative means. Then if there is any like non-homogeneous type, that means erythroleukoplakia, it has high chance of malignant potential. So in that case, what you can do, you can properly establish the diagnosis, you can go for an excision biopsy. So here I'll be sharing you our two histopathology report. The first is like a biopsy report. Second is like a radical specimen report. So both belongs to the same patient. You can see the patient died. The first is the biopsy report, second radical report. Both belongs to the same patient. So what happens is this particular patient reported to us with a proliferative growth over anterior two-thirds of tongue. So clinically, it was an obvious malignancy, obvious disease. So we took biopsy. That biopsy, it was, as I told, it was involving entire anterior tongue. In that case, we took a biopsy from both right and left lateral border of tongue. So you can see the impression: severe dysplastic squamous mucosa, hyperplastic, mild to moderate dysplastic. So only dysplasia is there. The pathologist was not able to come in any malignancy in this, but clinically the lesion was highly suspicious. But end of the day, the report was like negative for malignancy. So in this case, it can happen in some cases, like if your biopsy is not adequate, this can happen. In other way, it can happen in case of verrucous lesion. So there will be small points of invasion. So we cannot, like in our primary biopsy, we cannot get the malignant cells in exact primary biopsy in case of this kind of verrucous lesion. So these two scenarios will happen. So what we have to do in these scenarios, we should not leave the patient. We have to always correlate with the clinical finding. So we should not leave the patient. What we have to do is, what we did was, we did a radical surgery. That means wide excision of that tongue lesion. You can see the final HPR came as moderately differentiated squamous cell carcinoma with tumor size 4.7 into 3.3 centimeter. So end of the day, the lesion was PT3, and that means pathologically it was a T3 lesion. That means it is a stage 3 disease, stage 3 cancer, which eventually requires adjuvant radiation also, which will be coming later. But for the basic understanding, I am telling. So in such cases, what happens is, in your clinical scenario, sometimes you will be doing a biopsy. You are not sure about whether it is adequate or not, or if you are still feeling suspicious, refer to a specialist. Don't leave the patient. So these kind of scenarios can happen. Pathologist is not directly seeing the patient, so he can only comment the malignancy or invasion based upon the tissue that you are giving. So if that is not adequate, or the type of different kind of verrucous lesions, then the end of the day, the biopsy will be inconclusive. Then coming to FNAC, another tissue diagnosis technique. So it is usually mainly reserved for aspiration of palpebral masses, mostly used in head and neck for cervical nodes, then thyroid malignancies, then parotid malignancies. So in such cases, you can go for FNAC. So what this FNAC will tell us? This is basically, there is Bethesda system for thyroid and Milan grading system for salivary gland involving parotid. So what is Bethesda system? So Bethesda, further, they have classified into 6. Out of these, up to 4, they will be seeing, after the FNAC, they will be seeing certain characteristics, and accordingly they are classified. So 1, 2, 3, 4, those all belongs to benign. 5 and 6 are 5 is highly suspicious for malignancy, for like percentage is 60%, and 60 is proven malignant, like more than 90% or 97%. Similarly, Milan system for salivary gland, the one is non-diagnostic. In both Bethesda 1 or Milan 1 is non-diagnostic. That means the technique was inadequate, or the pathologist was, because he was not able to distinguish between any cells, only that was only a hemorrhagic aspirate. In that case, the patient, that doesn't mean the patient doesn't have any disease. Bethesda 1 means that the tissue sample was not adequate. So you have to repeat the procedure again, or you can go for either specific, more precise USG guided or something like that in order to get a repeat FNAC. So these are the basic information that you will be getting from a FNAC in case of head and neck cancers. Next, coming to imaging, DNE, that means diagnostic nasal examination, DLDB, direct laryngoscopy or direct pharyngoscopy. So basically, these are not a part of imaging. These are part of clinical examination itself. So in case, as I told, the cervical mass and non-primary, in case of carcinoma, hypopharynx, nasopharynx, you have to first go for a pan upper air or digestive tract endoscopy. So basically, these are the tools in that. So they are not a part of image. They are like part of a clinical tool itself. Then coming to ultrasonography, USG. USG neck, mostly used in head and neck cancers in early kind of lesions, T1 or T2, early oral cavity lesions or early head and neck cancers. We just need to establish the metastatic node. So USG itself got high sensitivity. That means high sensitivity and high specificity. That means it can give a better appropriate diagnosis compared to other modalities like CT, MRI, etc. So it is like cost effective also. So we'll be in early cancers. We don't want to well-defined lesions. We don't want to go for an imaging for primary, so we can go for a USG neck. So what the radiologist sees in this USG, you can see some sonographic feature over this left-hand side: size, shape, nodal border, echogenicity, matting, internal architecture, etc. So round, loss of fatty hilum, then echogenicity, all these together contribute a metastatic node. So loss of fatty hilum, round, then in microcalcification or internal calcification is known, all suggestive of malignancy. So these are the findings the radiologist will take from the USG neck. Then coming to contrast enhanced CT head and neck. So here you can see the first two pictures, axial view of CECT head and neck. So this is the soft tissue profile, this is the bony profile. The CECT head and neck is best reserved for oral cavity cancers like lower alveolus, buccal mucosa, GBS, gingival-buccal complex, RMT lesions, retromolar trigonal lesions, not tongue or floor of mouth. Okay, so all these lesions, for the both primary and neck, we can go for contrast enhanced CT and CT head and neck. So here, the very first picture you can see is differential enhancing lesion over the anterior lower alveolus. That means mandible. The same patient, this is the bony window. You can see the true bony erosion. Similar way, you can see a buccal carcinoma or left buccal mucosa tumor. You can see a well-differentiated enhancing lesion. This is a coronal view of the tumor. You can see the nasal cavity, maxillary sinus, paranasal sinus. Then this is the puff cheek view. You can see the oral cavity, tongue. This is the buccal mucosa. So here we have an enhancing lesion that is eroding the mandible. This is a sagittal view for the same patient. That is, here we can see this lesion involving the entire length of mandible. So this clinical scenario is called paramandibular spread. The lesion is having disease is having paramandibular spread along with the true bony erosion. So mostly in management part also, the entire hemimandible will go in these cases. So CCT head and neck, a good tool for both primary and neck. Similar way, contrast MRI. You can see in case of tongue, floor of mouth lesion, in cases where you are suspecting high infratemporal fossa lesions, where you are suspecting a nerve invasion. Then if you are suspecting a bone marrow invasion, in such cases, MRI is more sensitive than CT. So you can see a carcinoma tongue involving left lateral border, crossing the midline. Same patient, the coronal, this is the axial view, this is the coronal view. You can see the lesion abutting the neurovascular bundle. You can always compare the opposite side. Here you can see the sublingual gland and the neurovascular bundle, including lingual nerve and artery. So the lesion is involving both neurovascular bundle and the gland. Inferiorly, you can see the mylohyoid muscle. So the muscle is free. You can see one node over here, neck node. The same patient, you can see another axial section. It is a lower section. You can see a big node, metastatic node. These are the paired submandibular glands. So this is the level 1B station. That means submandibular nodes. Then So this is like a big primary tumor along with the significant nodal disease. So what we did is we went along with a metastatic workup. That means CT thorax, plain CT thorax. So we were able to find a metastatic lesion that you can see over the lower pole of the left lung. So these are like the imaging workup for a head and neck cancer patient. Then another one is PET scan, positron emission tomography. So what basically it is like, we will be injecting a fluorodeoxyglucose. That means glucose. The basic idea or basic philosophy is like this tumor cells or basic tumor cell, basically they need high they will show metabolic activity and they need high nutrition. So if you are injecting a radio tracer like fluorodeoxyglucose, the tumor activity tend to collect it more. So you can, in case of the mostly it is reserved for unknown primary setting and distant metastatic workup setting, then mostly recurrent setting in head and neck cancer. Head and neck cancer, mostly it is used for unknown primary, carcinoma of unknown primary. After imaging, after panendoscopy, you are not able to find the primary disease, you can go for PET. Then in case of previously treated head and neck cancer, then now patient presented with a local recurrence, you have to know whether there is any distant spread or not. In that case also, you can use the PET scan. So PET incorporated with CT will give the exact anatomical location. So already our diagnosis, our investigation, everything is established. Now what we have to do is we have to go for a staging. We have to stage the disease. Now we have to stage the disease. Further, we have to manage the disease. For staging, this is like AJCC Cancer Staging Manual, American Joint Committee on Cancer. Again, universally acceptable. If you're in America, if you're in Western countries, if you're in Europe, if you're in India, this is the staging manual. So the recent one is 8th edition, came in late 2017. So you have to follow the AJCC TNM staging. So basically, all of you will be aware about what is TNM staging: tumor factor, nodal factor, metastatic factor. So these things you will be getting everywhere. Like if you are reading, if you're browsing through the internet, you will be getting the further details of the TNM, what is it. So I'll be just explaining briefly. So this is the AJCC 8th edition. You have the tumor category definition of the primary tumor. That means T. T stands for primary tumor. So it will be like TX, that tumor cannot be assessed, T carcinoma in situ. Then T1, T2, T3. Up to T1, T2, T3, the staging depends upon the primary tumor size. In latest edition, there is something called depth of invasion. That means from the basement membrane to the deepest point of invasion. Some of the literature, some of the studies tells us that the depth of invasion have important prognosis. This depth of invasion itself can cause important aspects in the prognostication of the disease. That means it can affect the survival of the patient. So further, they classified according to the. So what they did is they incorporated along with the tumor size, they added this depth of invasion in the AJCC previous edition. That means the last edition currently which we are following. So the primary tumor size less than 2 centimeter, less than or equal to 2 centimeter, it will be T1 disease. 2 to 4, it will be T2. Then along with the added depth of invasion. Then coming to T4, there is little change. T4A, if the tumor sitting on mandible, or if the tumor in sitting as primary lesion is on the buccal mucosa, it is eroding the mandible. In that case, it will directly go as T4A lesion. In a similar manner, if the tumor involves skin also, it is directly considered to be as T4A lesion. That means moderately advanced stage. Similarly, if the tumor involves the masticatory space, that means tumor abuts or infiltrates the masticatory muscle, that means medial pterygoid masseter-temporalis complex, it is considered to be a very advanced local disease. So it got comparatively lesser overall survival of the patient. In cancer, we will always talk about the overall survival, disease-free survival, progression-free survival. So these are the tools that we'll be analyzing in various types of management. So coming to nodal criteria, same depends upon the nodal status. N1 means any node less than 3 centimeter. Then N2 further divided into 3. Then N2 means 3 to 6. N2A means 3 to 6. Then N2B means similar way the nodes, multiple nodes over the same side, or contralateral or opposite nodes, it will be like N2C. Then coming to N3A, the nodes greater than 6 centimeter, or any node with extra nodal extension. Extra nodal extension means the disease from the node, it breaches the capsule, it goes into the surrounding tissues. In that category, regardless of the primary tumor size, it will directly cause N3B. So these are the basic things. This you can read from all the articles or whatever steps you are having in and around in Google, you can go for it. Then AJCC prognostic staging tools. So what it stands. Suppose if a patient coming to you and he or she is asking you, doctor, what is my stage? What is my stage of disease? This is the staging that you are supposed to tell. So here, this is for the clinicians. So accordingly, this TNM staging, we can communicate with, suppose if you are working in India and you want to communicate about a disease to a doctor who is working in US, you can directly use these tools. So he easily understand, he can even prognosticate the disease by the staging itself. And he can give a valuable opinion about that also. So this, in that way also, it is important. In other ways, like in adjuvant treatments like radiotherapy, chemotherapy, or whatever treatment after the primary mode of treatment, that means surgery, you can incorporate this TNM. But the second one is prognostic staging group. Here we are something different. We are prognosticating something. You are explaining prognosis of the particular stage to the patient. So what basically it is? T1 N0, that means T1, T2 N0. T1, small tumor, no node, no mets. His stage is 1. T2, again the size of the tumor, no node, 3, stage 2. Then T3, stage 3, it will come as T3. In T3, 2 variations are there. T3, if there is primary tumor size of T3 lesion with no node or no distant mets, the stage will be directly goes to 3. Or T1, T2, T3, if any node positive, it will directly go as stage 3. Then again, stage 4 further divided into 4A, 4B, and 4C. 4A, obviously T4A lesion, it will come as, regardless of the N0 or N1 status, it will come as 4A. Then coming to 4, if the node is, regardless of the tumor size, up to T4A, T1 or T2 or T3, if the node is N2, that means multiple nodes or the node size is more than 3 centimeter, it will directly become 4A. Then any T, nodal status is N3, it will become 4B. Then primary tumor size T4B, any N, it will become 4B. Then last thing is any T, any R, regardless of tumor size, regardless of nodal size, if the patient is having distant mets, is considered to be a stage 4C. That means mostly that patient will not be for a curative intent of treatment. Up to T4, up to stage 4B, we can treat the patient in the curative intent with various overall survival prognostication data. So now we already staged the disease. Now what we have to do is we have to manage, we have to go for the definitive management. So before management, first we have to see the status of we have to see the patient. We have to clinically examine the patient. There is something called ECOG performance status, Eastern Cooperative Oncology Group. They similar to American Society of Anesthesiology, ASA classification. Here we have ECOG performance status in oncology. So what it tells us, it has grade 0 to 5. So grade 0, grade 1, grade 2, grade 3, grade 4, grade 5. So grade 0, fully active individual, he doesn't have any symptoms of the cancer. He's able to do all his activities without any restriction. He's a good candidate for surgery. Again, grade 1, restricted in physically strenuous activities. He is able to carry out all his activities other than hard strenuous things. Because what will be the limiting factor? Mostly the pain from the tumor. In such conditions, the patient is categorized as ECOG 1. Then 2, the patient will be ambulatory. He'll be taking care of his all self-care activities and he'll be having more than 50% of wake-up hours. So in that case, he's considered to be ECOG 3. In ECOG 2, then ECOG 3, little more debilitative condition like patient capable only for limited self-care. He or she will be mostly dependent on the family members, mostly confining to the bed. ECOG 4, completely disabled. ECOG 5, dead. So why it is important? So we will be seeing the patient, whether the management will be either curative or palliative. So first we have to see the performance status of patient. ECOG 012 are good candidates for surgery. We have to really think about treating a patient other than that. Then, more than age of the patient in oncosurgery, what we see is the performance status of the patient. Age is not a barrier. Suppose a patient is having 40 years, his ECOG status is 3 or 4, we cannot give a curative Indian treatment. In the similar way, if a patient is of 70 years old, he's having good PS of ECOG 1 or 2, we can go for a curative Indian treatment. So curative, either it is a multidisciplinary approach, it can be either surgery, like excision of the primary, then management addressal of the neck, then reconstruction, and with or without adjuvant radio or chemotherapy. Then another palliative radiotherapy, or palliative chemotherapy. Then the worst thing is it is further subdivided into best supportive care. Like we will be just addressing the patient's symptoms. The patient, mostly the best supportive care patients will be more than ECOG performance status 3 and very advanced stage disease. So in that cases, we will be just relieving the symptom of the patient. So in palliative radiotherapy and palliative chemotherapy, we will try to attain the disease. We'll try to make the disease stable. We will not be curing the disease while we'll be giving certain drugs or agents or radiation in order to make the disease stable. So the team comprises oncosurgeons, radiation oncologists, medical oncologists, then supporting team for diagnosis and investigation, radiologists, pathologists, then rehabilitation, which is a major important point, like involving speech therapists, dentists, physiotherapists. So what is the basic aim of our treatment? So it is complete loco-regional control. The first thing is complete loco-regional control. We should not compromise anything for that. We should not see the cosmesis. We should not see the function. We should see the complete loco-regional control. We should not compromise anything for that. The second thing is function, mastication, deglutition, speech, then maximum organ preservation. Then last comes this cosmesis, all these kinds of stuff. So our aim is to establish complete loco-regional control. So while going for management, again, this oncosurgery or oncology, it is evidence-based. Everything is evidence-based. Everything is protocol-based. We cannot directly, suppose if you're a surgeon, if you're an oncosurgeon, you cannot go for a separate parallel line of treatment of your own. It should be universally acceptable. So in that way, we have National Comprehensive Cancer Network, NCCN guidelines. All over the world, they follow the NCCN guidelines. So this already we discussed about the American Joint Cancer Committee staging and all. So AJCC, this ECOG kind of things, everything, these NCCN guidelines, they will take all these data and they will finally put new guidelines each and every year. Not each and every year, according to the rising cancers. So what we have to do is we have to follow the NCCN guidelines. So mostly this will be little confusion. This will evoke little confusion for you people seeing all these graphs and all. So I will make it very simple. So you can see the left-hand side, clinical staging, T1, T2, and 0, tumor size. So this T1, T2, and 0, that means early tumor with that means negative nodes. Early tumor with no nodes. The primary modality of treatment is surgery. So in that case, after surgery is done, you can address the neck, ipsilateral or bilateral, according to the location of the lesion. If the midline lesion, floor of mouth lesion crossing midline in case of tongue, you have to address the both sides of the neck. So then our surgery is over, primary surgery is over, addressal of the neck is over, then what is left? HPR, histopathology. Once this histopathology report comes, what you have to see is what are the adverse features. So adverse features, again, it will be tumor factors, it will be nodal factors, primary tumor factors. So if there is no positive nodes, no adverse factors, you can follow up the patient in early oral cancers. That means T1, T2, and 0. So in case of one positive node, other adverse features are, as I told, depth of invasion. If depth of invasion is more than 10 millimeter adjuvant, that means radiation is indicated. Then other adverse features is like perineural invasion, then involvement of the extranodal spread of the disease, then positive margins, close margins. So in case of extranodal extension of the disease. In case of the positive margins, you have to go for concurrent chemo radiation. So both modalities, or else nodal disease, metastatic nodal disease, that means N plus disease, you can just go for radiotherapy. So this is the basic outline of NCCN guidelines in treating oral cavity cancers. So this is the basic summary of NCCN guidelines. Early stage oral cancer, stage 1 and 2, can be treated by single modality. Locally advanced operable cancers, 3 and 4A, need to be treated with combined modality treatment like chemo, mostly adjuvant radiation. Sometimes in case of positive margins or in case of this extranodal spread, we have to go for chemo radiation, concurrent chemo radiation. Then all other metastatic cancer, palliative kind of treatment. That means symptomatic management. Then coming to surgical management. Surgical management includes wide excision of the lesion. It can be either in a composite resection, it can be either composite resection, that means involvement of the multiple components such as soft tissue, hard tissue such as bone, or it can involve full thickness excision, that means involvement of skin or primary with adequate margin. So next part, neck dissection. It can be selective, it can be modified neck dissection, it can be radical neck dissection. So all depends upon the lesion. So various approaches to oral cavity or Hedonic cancer, per oral lip split, pull through, mandibulotomy, that is more into a surgical field, surgical aspect. So neck dissection. So I'll be discussing about, till this time I was discussing about the nodal station, neck dissection, all these kind of things. So for the people who are not much aware about what this neck dissection or why we want to do is this neck dissection. So neck dissection is nothing but the removal of the fibrofatty tissue over the defined neck levels that already we were discussing, like level 1 to 7. So the removal of the fibrofatty tissue. So it can be fibrofatty tissue, it can be nodes. If in some case, in case of radical dissection, it will be non-lymphatic structures such as muscles, nerves, vessels. So why we want to do that? Cervical nodal metastasis is single most important prognostic factor in head and neck squamous cell carcinoma. What does that mean? What does that mean in the sense, if suppose if a patient is having whatever the primary size, the size of the primary tumor will be less than 2 centimeters, but the patient, the person is having a nodal, that means positive node, his overall survival or life expectancy is reduced by 50%. So that much important is the nodal status more than the primary. So further it is divided into, I'll be climbing up the ladder, it will be divided, it will be further classified as selective neck dissection, modified radical, extended, then radical. So selective neck dissection, in case of node negative patients, suppose if you are getting a primary tumor and your all investigation finished, imaging, finally you scale the disease like T1, T2 or T3 and 0. In that case, if you're doing a neck dissection, that will be selective neck dissection. In oral cavity subsite other than tongue and floor of mouth, the selective neck dissection will be level 1 to 3. In case of tongue, it will be 1, 4 due to some evidence of occult metastasis. Occult metastasis is to level 4 for about 5%. In some studies, it is up to 5 to 50%. So in case of tongue and floor of mouth, we'll be addressing the level 4. In all other cases, what we do is we'll be addressing up to level 1 to 3. Then modified radical neck dissection. In case of node positives, if you found a node, if you're diagnosed with nodal mets, in that case, you will be going for modified neck dissection. So the metastatic node, in that case, you will be clearing level 1 to 5, preserving non-lymphatic structures such as sternomastoid, jugular vein, all other structures alongside the nodes. Then we have radical neck dissection. Radical neck dissection, it is little more radical in case of metastatic node with extranodal extension, as I described as I mentioned in previous slides. Extranodal extension, whether the capsule of the disease breaches the capsule of the node and already the tumor is out of the lymphatic nodule. So in that case, we have to go for a radical neck dissection. So along with the primary nodal levels, we'll be removing either sternomastoid, internal jugular vein, or accessory nerve. So the modified radical nerve, according to the scenario or according to the situation, we will be either sparing muscle, vein, or nerve. That is purely based upon the clinical scenario. Then extended neck dissection. Any other thing other than this, any additional levels, any other additional structures you are taking along with your neck, it is called extended neck dissection. So nowadays, we are not directly mentioning like SND, RND, MRND. So we'll be mentioning like doing level 1 to 3, level 1 to 4. So specifically, we have to denote what are the levels we address in our surgeries. So we were discussing about neck dissection. So what is the basis of this neck dissection? Why you want to do this neck dissection? Already we were discussing about that, and we already established the fact that the nodal metastasis, we have to go for neck dissection. So why we are doing in case of node-negative oral cancer? So we have a landmark articles, landmark studies from Analytic Cruz, which was published in 2015 all over the world. Still, this study was from TMS, Tata Memorial Hospital, Mumbai. So all over the world, they are following according to this study itself. So he did a study like therapeutic versus selective neck dissection. Elective neck dissection in node-negative cancer. Elective neck dissection means you are upfront, you are doing a neck dissection without seeing the nodal status. Therapeutic means later stage, if you have encountered any nodal relapse, in that case, if you're going for neck dissection, that is known as therapeutic neck dissection. So he compared the population of these elective versus therapeutic group. So he found that the overall survival of the patient from elective versus therapeutic varies from 80% in elective and 67% in therapeutic. So that means more than 13% of the people benefited this therapeutic, which is very significant. So according to these kind of evidences, now we are following all early T1, T2 disease. We are upfront going for elective neck dissection. That means mostly SND, node-negative oral cancer, SNDs. Now, our primary is over. We address the primary tumor, we address the neck, we clear the nodal station. Now, what is left? Reconstruction. We have to reconstruct. So basically, reconstruction, we should reconstruct. Like if you are taking soft tissue, you have to replace it with soft tissue. If you're taking out bone, you have to replace it with bone. In similar way, the reconstruction should be established. So our basic aim is to achieve primary healing, maintain oral competence, facilitate swallowing. That means more of functional and less of cosmesis. So soft tissue defects can be reconstructed using skin flaps. So again, flaps can be classified from local, regional, mostly local regional flaps, then distant flaps. It can be either microvascular free tissue transfer. So we'll be taking the soft tissue along with the blood vessels. We'll be anastomosing that to the upper, like blood vessels around the neck. So this is a reconstructive ladder. So the ladder starts from above, like healing is the primary thing, healing by secondary induction in case of smaller defects. In case of small tongue primary lesions, we mostly do healing by secondary induction. We will not close the defect primarily. Secondly, in medium defects, up to more than 30% of the, suppose if you are taking 30% of the tongue tumor, then also we can close the tongue primarily. So in that case, we will be doing primary closure. In same medium defects, we can go for small to medium defects, we can go for skin graft also. Then all other defects which need local, regional, or distant flaps according to the site, age, and function, depends upon the what structures we are removing. So reconstruction of bony defects, reconstruction of mandible. In case of elderly patients where we have to finish the surgery, because of the anesthesia complication, we should not prolong the surgery. In that case, sometimes more than 70. In case of segmental resection of mandible, sometimes we will just go on with a simple reconstruction plate, or sometimes a bone graft reconstruction. But the problem with bone graft is if the patient requires adjuvant, again, osteoradionecrosis will happen and secondary infection will happen. In that case, we have to remove out the entire thing. Then ideal choice for the reconstruction of mandible is vascularized bone graft. It should be, the best thing is fibula, fibular flap, free vascular, microvascular fibula. So why fibula? Fibula got, because we can reconstruct the entire mandible with the fibula bone stock. It will get around 26 centimeter length. So we can fold it down and we can make it as a double barrel, like a gun, and we can put osseointegrated implants for dental rehabilitation in future. That is the one aspect. Otherwise, we can go for deep circumflex celiac artery flap, that means celiac crest flap, DCA flap, then radial forearm Curie flap, or osteocutaneous, which is less performed nowadays. So coming to reconstruction of maxilla, basically obturator, we can, for small defects, we can put an obturator and we can make it for secondary healing. Then non-vascularized bone reconstruction for defects less than 5 to 4 centimeter, mostly from iliac crest, which got a good corticocancellous stock. Then from vascularized bone reconstruction from the iliac crest, that means microvascular reconstruction, we can either go for fibula also in this case of maxilla. So this is the single reconstruction plate for mandible. Here we can see the harvesting of microvascular fibula, the postoperative orthopantomogram. You can see the reconstructed fibula with sufficient vertical height. So in these cases, later we can go for osseointegrated implants like basal implant. Either we can go for basal implants. Immediately, if you're going, means we can go for the normal titanium conventional implants. Next, our surgery is over. Adjuvant radiotherapy, chemotherapy. As I told NCCN, according to NCCN guidelines, if the tumor size is greater than T3, that means T3 and above, the patient needs radiation. If the depth of invasion is greater than 10 millimeter, the patient needs radiation. So radiotherapy can be, there are tumor factors and nodal factors. In nodal factors, obviously not positive. Nowadays, we used to give radiation for better oncological clearance and to prevent the future recurrences. So coming to radiotherapy, it can be either given as brachytherapy, that means interstitial or internal radiotherapy, then external beam radiotherapy. So mostly what we see nowadays is external beam radiotherapy in form of IMRT, intensity modulated radiotherapy. Mostly conventional dose for head and neck cancers, total dose of 60 to 70 grays in multiple days, fraction of 1.8 to 2 gray per day for 5 days per week. In total, weekly 5 days we'll be doing this adjuvant radiotherapy. Then altogether, the complete treatment time will be around 6 to 7 weeks. So total dose will be somewhere around 60 to 67 grays. Then hyperfractionation will be reducing the dose per each session. In the same way, we'll be giving the twice. What happens in hyperfractionation is we'll be dividing the doses. So smaller doses we'll be giving. In the same day itself, we'll be giving multiple sessions, smaller doses. So some evidences says it can increase the therapeutic differentiation between normal tissue and tumors, and it can further, it can give better outcome in that case. Then brachytherapy or interstitial radiotherapy. In this form of radiation therapy, what happens is we'll be implanting a radiosensitive, mostly iridium or palladium kind of thing, in mostly in head and neck cancers, carcinoma, small buccal mucosa, small lip tumors. In elderly age, we usually go for this brachytherapy. So we'll be placing the implants inside the body, then sensitize it. So you can see an example of brachytherapy of a carcinoma lip. The implant is placed in the iridium, the radioactive tracer or the sensitizing agent is placed inside the lip. You can see the complete healing of the lesion. Now coming to chemotherapy. Chemotherapy best reserved for most of the times it will be like used in a concurrent setting. So very advanced stage tumors with positive margins. That means the surgeon was not able to maintain adequate margins, then the final HPR came as positive or very close margins. In that case, you have to go for chemoradiation. Then in other case, if the patient have nodal burden, that too breaching the nodal capsule, that means spreading into the surroundings. In that case also we have to give for concurrent chemo radiation. So mostly what we use in head and neck is like taxanes, then methotrexate, vincristine, 5-fluorouracil, this kind of thing. Most of the head and neck regimen is like TPF regimen. That means paclitaxel, docetaxel, along with this 5-fluorouracil. These kind of drugs are mostly used in chemotherapy. This kind of chemotherapy concurrent setting will be acting as an adjuvant kind of therapy, not in a primary setting. In some cases, if there is extensive primary disease, we were discussing about T4A and T4B disease. This T4B disease involving masticated space, further it is divided into supranodes and infranodes. That means the nodes that we are mentioning here is like the sigmoid nodes of the mandible. If the disease is above the sigmoid nodes, what happens is it is having high chance of perineural spread. That means spread along the mandibular nerve. So in tumors like supranoid tumors, in tumors with big soft tissue edema, in that case, we can either go for neoadjuvant chemotherapy, that we will be giving some chemotherapy in order to reduce the tumor bulk. So that doesn't mean that we will be reducing our margins. Our surgical margin will be same as the previous, before the NACD, that means neoadjuvant therapy. It will be the previous, it will be according to our previous scan. So we will be seeing the response of our chemotherapy or neoadjuvant chemotherapy. So accordingly, we will be operating the patients in case of very locally advanced disease, in case of T4B. So that is another entity of chemotherapy, that we are giving chemotherapy before the primary surgery. So such type of therapy is called neoadjuvant chemotherapy. Then something called oral metronomic chemotherapy, mostly best reserved for palliative patients, recurrent setting. In drugs such as methotrexate, 15 milligram per kg, where we'll be giving in small doses in order to have some kind of stable disease. So mostly some report review reveals that it doesn't have any therapeutic value. It is just a kind of placebo. So we don't have much evidence for standardizing that. So mostly chemotherapy will be either adjuvant along with concurrent radiation, or neoadjuvant before the surgery, in order to prepare the advanced stage tumors, in order to prepare the patient with advanced head and neck tumors. So now I would like to conclude with this final slide, like role of dentist or oral physician in oral cancer management. So basically, they are the more exposed. Those people are the more people who are exposure to the oral cavity. So they are treating mainly the subsides of the head and neck. That means majority of the head and neck cancers belongs to oral cavity. So they have the major important role in the primary or early diagnosis. Early diagnosis, good survival. So they can further counsel the patient regarding the adverse habits, or maintaining the hygiene of the oral cavity. They can prepare the patient for the surgery or adjuvants like scaling, extraction, application. Then maxillofacial prosthodontists, they can give better post-operative rehabilitation in case of carcinoma maxilla, carcinoma palate, in case of like fabrication of obturators. In case of carcinoma nasal cavity, they can give prosthetic nose, prosthetic eye. All these things will come under specialist dentist or oral physician. So thank you. Thank you once again. Thank you, Dentist Channel Online, for giving me an opportunity in order to share my views on this topic.
Overall, so thank you so much, Dr. Ashwin, and you explained every topic so well, and it was so insightful. And now there is a question and answer round. So I would request to all the attendees to put up their question in Q&A box or in the chat box. So I would like to share my screen. Dr. Ashwin, can you stop sharing your screen, please?
Oh, yeah, sure.
Yeah. So I would like to request to all attendees to put up their questions. Before that, I would like to share my screen regarding the dentist channel online. So yeah, Dentist Channel Online is emerging to be the largest platform, that is a digital platform who supports all kind of upcoming dentists or the surgeons, dental surgeons, especially in their academic field, professional field, or anything like that. So our services is mainly for the dental professionals, dental students, and for the dental organizations. Here we support and we request all dentists to come up and conduct the webinars and the courses, events, so whatever they want, they can access to this Dentist Channel Online. So talking about the key highlights, we have conducted 700 plus live dental webinars, along with that 40,000 participation certificate issued, and then 25 plus dental workshops, 400 plus national and international speakers are there in Dentist Channel Online. So this is a kind of like a record, and we take pride in sharing that Dentist Channel Online, this channel has entered into the India Book of Records for having maximum speakers participating in a virtual conference in oral implantology. So I would like to tell all the attendees that you must access this Prime member and what are the benefits of the Prime membership. So you will get the regular updates and news regarding the dentistry, and you can access to scientific like articles and other webinar sessions. You can participate as a speaker. You can publish your own like a video or any awareness video, and there will be certification by recognized institutions like with CPD or CDE points. I hope you all might be knowing about these points. And you can also get a special discount on dental courses. Along with that, access to all the webinars organized by the Dentist Channel Online, and you will have your own personalized account with access to profile. So this is the diagram, or you can say a photo of the certificate that you can get after participating in this. And that's why I'm telling that just hurry up and be a member of a Dentist Channel Online to access these all benefits. So it is rupees 799 per year, which is equivalent to $10. And yes, if you use my promo code, that is SJ100, so you can get Azure discount. So I repeat, the code is SJ100. And these are the upcoming webinars in the Dentist Channel Online. The first one is the study options for foreign graduation in United States and Canada, following with the laboratory procedures in the cast partial denture. And the next one is the periodontal disease and systemic conditions, that is a bidirectional relationship. So you can access this channel via Facebook, Twitter, Instagram, LinkedIn, YouTube, WhatsApp, Twitter, or Telegram, any SNS account. And this is the address. Yeah, this is the address of the Dentist Channel Online. And if you have any queries, so you can have this phone number, you can have that query resolved. So this was all about the thing. So I would like to request to all the attendees to just put up your questions. Yeah, I have received some questions. So there is one person, that is Tengzeri Nongram. Okay. Thank you, sir. I was one of your junior from SGM. It was a great presentation. Okay, this was not a question. It was just a thanking thing. And the next one is from the S. Bala Subramaniam. What is USG? Is it ultrasonography?
Yeah, it is ultrasonography.
Okay. And again, there is a question from S. Bala Subramaniam again, that what is CECT?
CECT basically means contrast enhanced computer tomography. We have CT imaging. So if you're injecting a radioactive or radio traces such as iodine before the procedure, it will better enhance the soft tissue structures. So basically the CT scan will enhance the contrast enhancement will help us to distinguish between the various normal soft tissues and the malignant things. And it can further dealing it from the, because in some cases we will be having the primary tumor abutting over the nerve muscle and all. So in that cases we can better delineate with the contrast. So contrast will help us for better soft tissue delineation. So this contrast is basically not only restricted for CT, it is basically for MRI also. In that case, we'll be using gadolinium.
So I hope that S. Balasubramanian, he might have got his answer. Yeah, understood, sir. Okay, yeah, he got his answer. So thank you once again, Dr. Ashwin, that it was a very insightful session and you explained each and every terms and everything very clearly. So as I'm also doing that oral maxillofacial surgery, I'm also doing that master's. So it was a very good session for me too, because I learned very important things and I think it will help me in my future endeavors. So thank you so much.
For your future endeavors. Yeah.
Thank you so much. Thank you so much, sir. So now we are going to end the session and yeah, thank you, sir.
Okay, thank you.